Hello, it's infant feeding time again, Facebook Live, 2:30 on Thursday. I'm hoping that you've got a ton of good questions for me this week, so I'm on my own again. Naomi's on leave, so she's always good at filling the gaps, so I'm not quite so good at that, so she's brilliant at it. So I'm hoping I'm going to start seeing some faces pop up. I often can see the names, the faces, the icons coming up, so I'm looking forward to seeing some people joining me. I'm hoping I'm not talking to myself. Brilliant, there are people joining me now. Fabulous, that's lovely. So I've just been talking to some dietitians about protecting breastfeeding and ensuring that mothers who might be readmitted with their babies onto the children's ward get really good support. So we've just been talking about ensuring that mothers have access to a pump if they need to, and the right support to help them keep feeding even if their babies might be a bit unwell. So yes, it was really lovely to go and talk to them. They're all some great members of the teams and within the hospital, there to support parents and wanting to know how they can best support mothers and families with feeding, understanding what makes the difference and what will help a mother keep going. So yeah, our role's quite varied when it comes to infant feeding. So we've done clinic today. So this morning I was in breastfeeding clinic, and I've seen some lovely babies. And we see babies from 7 days to 6 weeks, and we've seen the total spectrum. We had a baby in of 7 days, and we had a baby in of a whole 6 weeks. Such a big difference. It's amazing. And any of you out there who've got babies who are sort of near that 6-week mark will be knowing how different your baby is from that 7-day-old baby. Initially, they change so much, but it's so wonderful to see them growing up. So I'm just looking to see if it's coming up on my computer, because it means that I'll be able to see if anybody's sending me any messages. So I'm hoping I can see lots of lovely icons coming up. I can see that there are people watching, so welcome. So as I mentioned at the beginning, this is the infant feeding session. So if you've got questions that are specific to other aspects, so for instance about scans or visiting or made of birth, then those are all for Wendy Randall's sessions that she runs on a Monday. She does those sessions, and this session is about feeding. So anything to do with feeding, whether it's you haven't had your baby yet, your baby's a week, 2 weeks, a year, 2 years, whatever, it's to do with feeding. And also we cover sort of those early days, what to expect, thinking about sleep, sort of what to expect of a newborn baby. But yeah, thank you very much for joining me. I can see you there. I'm looking forward to some questions. I thought while we're waiting for the questions to come through, we can think about pumping, because that often comes up, pumping. And I picked up a postcard, which I now cannot find, talking about pumps. So just to say that pumps are quite personal as to which ones work for different people. So a pump that works for one person may not be brilliant for another. And if you've been through the hospital here, you'll know that we have so 3 different types of pumps on the ward, made by Ardo, Amida and Medela. And people will normally know them as the green or the yellow pumps. So they're all great, and all 3 of those companies make domestic pumps, pumps for you to use at home. So they use their technology for our hospital grade pumps, but they put them into a smaller version. So any of those pumps would be a great pump if you were thinking of or needed a pump to buy. But also to think that when your baby's first born, and those that have already been there will know this, that actually we're not encouraging you to go on a pump initially. So if you are having any problems, if you've got a sleepy baby or a baby that's not attaching, or you're a bit sore, then we might be encouraging you to express, but we'll be getting you to express with your hands. And hand expressing is something we talk about on these sessions a lot, because some people choose to do it before they have the baby, and then others will find themselves needing to do it once the baby's born. If you're a mother who has diabetes, or your baby's going to be a bit early, then it's well worth having a go at hand expressing before you've had your baby, just to learn the skill. And we talk about this quite often on here. And even if you haven't got those risk factors, just being acquainted with how hand expressing works will be really beneficial, because if you find yourself having to hand express in the early postnatal period, you'll probably be very tired. Mothers after birth are very tired. It's hard work having a baby, and actually knowing how to hand express before you've even had your baby is really helpful. So whilst I wait for all your lovely questions to come through, I'm just going to go through hand expressing, which we do many a time, and think about what you're going to be doing. So it's Thinking about oxytocin. Oxytocin is a shy hormone, so sit somewhere nice and warm, sit somewhere comfortable that you're not going to get walked into. If you're doing this postnatally and you're feeling a bit sore, get some pain relief. You know, ask them to come and give you some pain relief before you start, because oxytocin can be inhibited by cortisol. So if you're feeling you're in pain or you're a bit concerned, then those stress hormones can knock oxytocin out. So try and be in as good a place as you can be. So thinking about massaging the breast, and it can be anything you like. It could be rolling, it could be stroking, it could be round, and I've even heard of people taking a comb and combing the breast because it feels nice. So anything like that. If you've already had your baby, having your baby nearby will help, because that brings out oxytocin. Looking at your baby, thinking about your baby, stroking your baby, chatting to your baby will get oxytocin flowing. And then making a C. Now you'll hear us all talking about making a C, and the C is your thumb and finger, and we want your thumb and finger to try and meet. So you're going to work your way back. So the first thing you're going to do is find the right place from the base of the nipple, and you're going to find where it's lumpy and bumpy. And I had a lovely mum the other day describe it to me as bubble wrap. She said it feels like bubble wrap. So you're going to find where that bubble wrap is, that lumpy bumpy bit, and it's going to be probably 2 to 3 centimeters back from the base of the nipple, and you're going to anchor your thumb and your fingers, and you're going to bring them in and hold. And it's no sliding because you'll get sore. It's in and hold. Keep it, keep it, keep it, keep it. Release and go again. Get a rhythm going. Keep going. Now this is such an important thing to learn, that actually it's included in your postnatal care plan, and you keep that rhythm going, and it's in and hold. The hold is long, the release is quick. In again, hold, and keep it, keep it, keep it. And you work one area at a time. Think about your breast like a piece of broccoli. So the stem is the nipple, then the branches go out, and the flowers of the broccoli are where the milk is produced. The oxytocin releases the milk from back here and drops it down through the ducts, so that when it's ready for you to then get it out, or the baby to get it out even better. So it's thinking about, you know, sort of how you remove the milk. So hand expressing is a great thing to learn. If you get home on your first night home, you've been here and you go home, or maybe you've had your baby at home and your baby's fast asleep and you think, oh, I'm sure baby needs a feed. Hand express, get it on a teaspoon, give it to your baby. Even a baby that's sleepy will take it. You can pop a finger in and get your baby to suck your finger and drop the milk on, and your baby will have a feed. If you've got a baby that's really upset and you can't get them to attach, hand express. It's absolutely brilliant, because that way you can again get them to suck your finger, drop the milk on your finger, get them to take it that way. Or you're feeling really full because your milk's come in. Hand expressing will do a brilliant job to get your breast softer, to let the baby come on the breast, because when your breast is really full, it's very, very difficult for the baby to take a good big mouthful. So soften the breast, get the baby on, and that'll be somewhere between days 3 and 5 when your milk comes in. So these are the things that you might want to be doing hand expressing for, and they're really, really good tool. So when we look, you know, we talk about our postnatal care plan all the time. When you've had your baby, and those out there who've had them will know this document, it's your postnatal care plan, and it's as much for you as it is for us. So it has a section all about you, what's happened. Oh, I've gone onto the wrong page. That doesn't help, does it? So this is all about you and what happened with your birth. This is a checklist where we do check you and we check your baby, and this includes what the poos and wees are doing, because that tells us so much, and I know we talk about that all the time, but they're your signs that your baby's getting food, that the poos are changing from black to green to yellow by day 4. This is where you can record all your fees and your poos and wees, so we know what's happening. And then on this page, this is where we do our feeding checklists, and this should be done before you go home. So if it hasn't been done and you're about to go, ask someone to come and fill it in and make sure you know what you need to do. So this is observing a feed. So someone should have seen you feeding before you left, and someone should teach you to hand express. And that's why I'm saying it's so important that we have it here, and everybody should leave having at least these 2 sections completed. If we've put a feeding plan in place, it's going to go in these sections. And then there's a wonderful checklist at the back, and anyone out there with a new baby who wants to know, am I doing a good job, look at this checklist at the back. It's pages, I never remember, 10 and 11. The top of the page is a baby that's less than 72 hours, and the bottom of the page is more than 72 hours, because things change. Now, we often get told that mums feel they hear conflicting advice. So we tell you that in the early days, tiny weeny amounts of colostrum is fine. And then as time goes on, we need to tell you to give more and more and more. So people sometimes see that as conflicting advice, but actually it's a situation changing. And that's why when you look at this checklist, this is a baby that's under 72 hours and this is a baby over 72 hours, because the situation is changing daily with newborn babies. if you look at this and you think, am I doing a good job of feeding? You can look down this section here, and if you can answer all those questions with the green column, everything sits in the green, you know you're doing a really good job. If you find that some of the answers are sitting in the yellow, then ask for a bit more help. Let your community midwives know that you need a little bit more help. So that's regardless of whether it's pre or post 72, this is a very good indicator of how things are going for you. And it's a really good way for you to know and not to have to wait to speak to somebody. So if you do that checklist, it could be the middle of the night. You're thinking, oh no, am I doing a good job? Have a look and see. Now I can see we've got some questions coming through, but interestingly enough, it's not coming on my computer. Why are we not getting this on my computer? Let me refresh. See if I can do it. It's much easier to read the questions on here. There we are. Up they come. Right. Now, hopefully you won't have any problems. We had a few problems in the last couple of weeks. Leanne was trying to put a question up a couple of weeks ago and it didn't load. So if the question doesn't come up, if I don't answer your question, I seem to skip it, let me know, and maybe have to break your question into a couple of bits because it seems to be long questions that don't come through. Erin has said, at what stage in pregnancy should we start hand expressing? So we would not recommend that you start hand expressing until you're 37 weeks, please, Erin. You can have a quick go at 36, see how you're doing, but normally 37 weeks, not before then. There's a very, very small risk that it might put you into labour, and we don't want to do that. Now, if you happen to be like the lovely lady I met earlier this week who was going to have a baby early for medical reasons, then she was going to be hand expressing earlier than 37 weeks, but it was in a controlled environment. She was up on the ward, and we knew that she was going to be induced the next day. So should it have an impact, it wasn't going to have a big impact. But normally we would recommend that you do not start before 37 weeks. And you can do it probably 4 times in that period of time. Now bear in mind, when you start hand expressing, the likelihood of getting anything the first time or even the second time or even third time is slim, and some women never get anything in the antenatal period. This is not a reflection on what your supply will be like going forward. So don't feel disheartened if you never get anything in the antenatal period. If you do, it's fantastic and it's a bonus. But just to say, any hand expressing you do before you have your baby will not have an impact on your milk supply going forward. So everything you do after you have your baby affects your milk supply. So if you don't express, you won't have a milk supply. If you do express, you're going to push your milk supply. So it's thinking about that. But what you do before is just a bonus and doesn't impact on your milk supply, and it won't bring your milk in. Hopefully that answered your question. And Erin, if you go onto the hospital website, the OUH maternity feeding, there's a leaflet on there about expressing while you're pregnant, and it goes through why you might want to do it and how to do it. And we also have a video, if you go onto that, again, that website, OUH, if you literally do a search, OUH maternity feeding, there's a link to some videos, and we did one about hand expressing, so you can have a look at that as well. So you could look at the leaflet and watch our video. And there's a lovely video that we did of a fantastic mum who let me film her hand expressing, and it shows you, and she's very dexterous because she's managing to collect her colostrum at the same time. Many mums will need a bit of help collecting the colostrum initially. It's quite an art to do both. Right, so hopefully that's answered your question, Erin. So Stephanie said, hello, hope you're well. My baby's 10 days old. She's currently feeding at least a couple of times an hour, but she isn't staying on the breast for longer than 10 minutes each time. We're finding that she's very unsettled at night, but sleeps well during the day. She's had jaundice, so we have been told that that can make her sleepy. She latches well, but can sometimes take a little while to latch. Any suggestions to help her settle more? So first to say, it's very normal for babies to be awake more at night than in the day in the early weeks. That's really, really common. She's being a very normal baby. When I was a student midwife, I worked with a lovely midwife who still works locally. She's not a midwife anymore, but she works in another role. And she used to say that in our caveman days, it was much safer for babies to be awake and feeding at night than during the day, when mothers would be out and there was a risk of predators. So that was how she put it to me. So if you think about your baby, it's all, your baby's working on a very sort of survival mode, and so for your baby, they think it's much safer to be awake at night than during the day, and I can see the logic of that. So it is really common that babies are awake at night, and often mums, when you speak to them, and it may be the case for you, Stephanie, too, that you found your baby was awake a lot at night anyway, when before you even had your baby, and actually that's their normal rhythm. We think by about 6 weeks it begins to start turning a bit more. Babies can begin to sleep for a little bit longer, and they begin to get an understanding of day and night, and that actually you can start seeing a turn. So those who've got babies of over 6 weeks might come on and just go that they've noticed that happens, but it does improve. I think you said that she's feeding a lot. She's feeding a couple of times an hour. I'm just wondering if you're offering her both breasts at every feed. And I mean, that's lovely that you're being so responsive to your baby, but I can imagine that's extremely tiring. And as you're 10 days old, have you still got, are you still under the midwives? Are the midwives coming out to see you? Might be worth them having a look and see what your positioning and attachment is like. Can we improve it? Can we make your baby a little bit more efficient when they're at the breast? So, you know, thinking about maximising the support that's out there and getting someone to have a watch and just see, is your baby going on as well as they could be? What colour are the nappies as well? Because, you know, if you're getting lots of yellow nappies, the likelihood is that your baby's doing a good job. If you're getting green nappies, then it might be that your baby's doing a lot of snacking, getting a lot of that sugarier first part of the feed, and maybe not quite getting through to the fattier part of the feed that tells your baby that they're full. So you mentioned about the jaundice, so that does impact on babies. Babies can be very sleepy with jaundice, but it tends to go as they get more and more food in them. So you're obviously doing a great job of getting food in your baby, but I can imagine that feeding a couple of times an hour is quite hard work, especially at night when you're probably at your lowest ebb and could really do with some food, could do with some sleep, sorry. So I think maybe if you're still under the midwives, get a midwife to come and check your positioning attachment, or one of the maternity support workers. Let me, you know, if you've got any concerns about those nappies, mention that too. If the nappies are green, that would be reflecting on maybe the baby's snacking and maybe not doing as great a job as they can at the breast. But with regard to being awake at night, that's pretty normal, I'm afraid, and hopefully we'll get better with time. Stephanie, I hope that answers your question, and I do feel for you. It's really tough when you're up lots in the night. It's really hard time to be doing it. So but keep in touch and access more support. Tanique has said, hi there, I've been exclusively breastfeeding my 4-week-old. The past few days, my right nipple has been sore and looked cracked. When putting him on that breast, I can see he's getting milk, but he's extremely fussy, pulling and pushing away from the breast and clamping down, which is very painful. I then place him on the left breast and he doesn't fuss and fall off the breast, asleep and full. Why is he fussing so much? Has it got something to do with my nipple being cracked and sore? Is it affecting my supply in the breast? So I think in the long run it may affect your supply, Tanique, because the baby's not feeding on that breast quite so well. I wonder if it's because you're doing so well on one side that the likelihood is that it might be just, again, I'm going to say it again, positioning and attachment, just going and having a look what's happening on that side. Get someone to film you feeding your baby on one side and then feeding your baby on the side that you're struggling with. See what the difference is. See what's happening. You know, it can be as simple as that your breasts are not identical, and nobody's are. We were talking about that this morning. I had a student in clinic and we were talking about the fact that sometimes it's much easier to feed on one side than the other, and our breasts are all different. And we have a teaching slide on one of our sessions for midwives, and it has breasts, and there's a whole section of breasts, and I love it because they have these breasts, and nobody's breasts are identical, and these ones are 2 different colours anyway, but when you look at the pictures they're sort of like this, you know, they're all different ways round, and we are all different. So it might just be that you've got one breast that points out one way and one breast that's slightly different, and actually it may just be that you need to get your baby on in a slightly different position on that side, and the two things are related. So if you've got a baby that's not getting the mouthful they're looking for, because your baby knows what they want because they're getting it on the other side, then actually going on the side that is damaged, and the damage is because the baby's not going on as well as they can be, your baby's going, this isn't right, I know it can be better. So I think, start with getting someone to film you on the one side and the other. Think angle of the dangle. This is what I was meaning just then. So, you know, thinking about where does your breast point, bring your baby on at the angle that the breast points at, and it's very likely that your breasts are slightly different, and where you might have a baby coming up here on this side, on the other side you might actually want your baby more straight on. So it's thinking about how do you want your baby, so babies come from here or here, thinking about where you're doing and making sure that you're always going for that really asymmetric attachment. Are you doing it as well on the good side as you are on the other side? So because you've done such a great job and you're more than 50% there because you're doing so well on that side, I would look at positioning attachment. Get someone to watch you. You know, it could be someone films you and then you look at it and go, okay, what's the difference? If you can't see the difference, access some more support. It could be us, it could be Oxford Breastfeeding Support. I mean, if you've got videos, you can send them to us and we can have a quick look and see if we can see what the difference is, or do an online call, save you even coming into clinic. Because I'm sure that the fact that you're getting it absolutely spot on one side means that it's only a tweak to get it right on the other. So keep going. Obviously the risk is that you are going to have an impact on your supply if you don't get this baby feeding well on that one, but the fact that you've already been there, you're 4 weeks down the line, you will get the milk supply back up again. So I think you can be reassured, Tanique, this is just a little blip in the road, and actually things will get much better from here once you access a little bit of support. So videos, if you can't see the difference, get in touch with us, send them to us, we'll have a quick look, and if need be we can do an online chat and go from there. So good luck with that. Erin's come back and said thanks so much. Amy's come on. Hello Amy, we haven't seen you for a while. And that's why, because your baby has just turned a year old. Her breastfeeding journey is still continuing, beautiful and bonding. Thank you for that, because that's reassuring for those out there that are struggling. So, you know, I know Amy's name because Amy's been through our services, which means that she had a few problems at the beginning, which means that she's now got through them. And that's just, I love it when we can say to all of you that are listening, you know, actually things do get better. You know, it can be tough in the beginning. I know I've said it on here before. The Association of Breastfeeding Mothers had a poster campaign, and it's not easy, but it's worth it, because once you get through those initial few weeks that can be quite challenging and hard, it gets so much easier, and you've got the perfect milk on tap in the best packaging ever, ready for your baby whenever they want it. So thank you, Amy, for that. That's lovely. Kate's come on. Hello, I've been exclusively breastfeeding my 4-week-old with no problems. We're now looking to introduce a bottle for some feeds so my husband can enjoy this part as well. I've begun expressing once a day to build up a small freezer stash. Well done you. My questions are, how much should we offer per feed? I've no idea how much he normally gets from the breast. And how often should we offer a bottle? We don't want to cause any nipple confusion. Well, the first thing I'd say, Kate, is that as your baby is 4 weeks down the line, they know where they like to get their milk from, and so I think it'll be more of an issue getting the baby on the bottle than keeping them at the breast. So we'll come to that in a second. So thinking about maybe not doing it too often. Most often the norm would normally be, I think, when we talk to mums about doing this, is giving a bottle in the evening, and some mums find that really lovely because it means they can maybe go to bed a little bit earlier, or they can break that cycle of sort of cluster feeding in the evening, and it gives mum a break. You know, it might be you can go off and have a bath, or just take a bit longer in the shower, whatever. When you're thinking about volumes though, so we're going to go back to our pictures, when we're thinking about volumes, we're thinking about an egg. So we think an egg would hold somewhere between 80 and 150. So when you're thinking about your milk, what we would think about doing is probably doing the lower end first, but having some ready to give a bit more if your baby's looking for more. So have a bottle ready to be given, and a bottle of additional milk if it's needed. So it might be that you keep the milk that's been expressed. So, you know, so from the point of view of when you first start doing it, before when you work out what sort of volume your baby might like, rather than defrosting, use the fresh, and so that if it doesn't get used, it can go in the freezer afterwards or go in the fridge for the next day. The reason that we suggest you do it in that way is that, think about if you started with a sort of maybe 80 max, and then have a little bit to the one side ready. If your baby drowns the 80, takes it all, or downs the 80, takes it all, wants a bit more, you just top it up. If you'd put the whole lot, the whole 150 in one bottle, and your baby didn't take it all, then actually you're going to have to discard what your baby doesn't take. So when it comes to topping up or doing feeds like this, we'd always start minimal amount first and just keep topping that bottle up from a clean bottle. That bottle then is clean enough to go back in the fridge or in the freezer, so you haven't wasted it. So going back over what about this is that thinking about maybe once a day offering the bottle, it can be quite challenging if your baby has never had a bottle to get them to take a bottle. So maybe using somebody else. Do it when your baby is not necessarily really hungry. So if a baby's really hungry, they're going to go, well, I get my milk from the breast, I don't know what this is. So do it at a time, maybe in between feeds. Let the baby get used to the idea of a teat in their mouth. Don't expect them to take it straight away. It might take a bit of time, a few days, a week, for your baby to get used to the idea of a bottle. If your baby starts to get upset, stop, go back to breastfeeding, and then try another time. Do not, because it can become a really negative cycle. So if your baby's is there, desperate, wants to go back to the breast, and you're trying with the bottle, you get to the point where the baby would never countenance a bottle. If you do it little bit by little bit, your baby's more likely to do it. Having said that, you never know, Kate, your baby may take to the bottle straight away, but we've seen all ends of the spectrum, and I think it's not making it a battlefield, it's keeping it something positive and nice. Possibly using your partner to do the bottle right from the beginning. So the partner does the bottle and your baby knows you're the breastfeeds. And I'm sure if your baby gets used to a bottle, they would take a bottle from you in the future if they needed to. But in the first instance, I would start partner doing it. And maybe you not being around might even help as well, because the baby's going to look at you and go, but you give me the milk and I don't normally have it from a bottle. So not expecting your baby to down it in the first instance, doing it little by little. Partner may be doing it, not making it a battleground would be the main things. Keep it a positive experience. And when you're thinking about volumes, 80 to 150 would be a normal stomach size, and thinking about starting at the lower end and then just adding to it as and when, if the baby's looking for more food than that. I hope that helps, Kate. So see how you get on. And you mentioned about the nipple confusion. Just to reiterate, your baby is used to breastfeeding. We don't tend to have issues with babies when they are used to breastfeeding. We have issues with babies that are not used to breastfeeding, have had a lot of bottles in the beginning and then can't get used to the breast. So I would think in that instance, once your baby's worked out how to feed from a bottle, and it is different, once they've worked out how to feed from a bottle, they will cope with going from one to the other. So good luck. I hope it goes well. Thank you. Thank you. Stephanie's come back. Thank you. I've been offering both breasts at each feed, although sometimes she falls asleep. We're still under the midwife at the moment. I think we're being discharged tomorrow. She's lots of yellow nappies and also wet nappies. We've had breastfeeding support, but we'll ask for more tomorrow. And I think say to them your baby's feeding twice an hour, a couple of times an hour, because we wouldn't expect your baby to feed that much all the time. So just if you've got, it's not uncommon to have a period of time in the day of a few hours where baby does that, but we would anticipate at other times you'll have longer periods when your baby isn't feeding. So I would make sure you get some help tomorrow, maybe even phone today and say, I know you're coming to discharge me tomorrow, can you allow a little bit more time to help me with feeding, please? So and see how you get on, Stephanie. Erin's come back. Me again. Like it, with a smiley face. Thinking in advance, we'd like to have baby on just breast milk, mainly from the breast, but on occasion use expressed milk for dad's sibling to feed. I'm worried they'll stop taking breast if I introduce the bottle too soon. Is there a trick to this, or should I just do breastfeed only for a while? Well, it goes back to what we've just been chatting about a moment ago with Kate's question. I would get breastfeeding established. Don't start with the bottle too soon. Get those first couple of weeks under your belt, and then think about maybe introducing a bottle after that. When I was an NCT breastfeeding counsellor, we always used to say not to do pumping or anything until 6 weeks because it impacts on your milk supply. The only thing is, I will say that I do know that babies that we leave them longer and longer do get to the point where they go, well, I don't know what this bottle is and I don't know how to cope with it. So maybe not leaving it too long before you introduce a bottle if that's something you know you want to do. Breastfeeding, babies learn how to breastfeed and they can learn how to bottle feed, but it's establish breastfeeding first and then think about doing the bottles. Just as I've just said to Kate, not making it a battleground, introducing the bottle and keeping it something nice, not doing it when they're desperately hungry, so they get used to the idea of what's it being in their mouth. So the answer to your question, should you just do breastfeeding for a while? I would say the first 2 weeks it would be great if you could just establish breastfeeding and then think thereafter about introducing a bottle if you want to. Sometimes we have to introduce bottles sooner, and that might be when a mother's struggling to get the baby to take milk. As I mentioned when I first started this session, I've just been talking to some dietitians about feeding and how to help, how they can help mothers with feeding. And I was talking about protecting a mother's milk supply and how, what we're doing with that. So sometimes we struggle when a baby has maybe not gained enough weight, and we look at transfer, production and absorption. Why is this baby not gaining enough weight? And in those instances we might get a mother pumping, and we might be introducing a bottle much earlier than the 2 weeks. It might be, you know, maybe even sort of in the first 5 days. So on occasions we do introduce bottles earlier, or we do cup feeding as well, the other alternative. So ways of increasing the volume of milk a baby's getting if they're not gaining quite as quickly as we would like them to. So I think I've talked about how you can introduce a bottle, and thinking about concentrating on feeding in the first instance for the first couple of weeks would be ideal. Get it established. It's a learnt skill for both of you to learn, and when you've both mastered it, then you can think about doing something else. Tanique's come back and said thank you, and Kate said thank you as well, and Erin has come back. Perfect, really helpful, thanks so much. Right, oh, no more questions. Right, ladies, gentlemen, please send me some more questions. So just refresh, because I know what happens sometimes, they don't come through. So if you've put a question up and I haven't said anything and I haven't mentioned it, please pop it through again, because we have had a few instances recently where they don't come through. Sometimes it's when they're slightly longer questions we're not getting them, so you know, it is a bit difficult in that instance. They don't seem to come through. So I think it's been a bit of a theme, and we often talk about expressing and using bottles. So from a point of view of a baby learning to breastfeed, when a baby's feeding, they are going to take a really big mouthful of breast, and this is, I always use my hand to explain it, and then lovely knitted breast. They're going to take a really big nice mouthful of breast. And anybody who's met us will know that we talk a lot about asymmetrical attachment. So when a baby goes on the breast, we want one moving part. So any of you out there who are struggling, or are, and even those that, you know, we had the message about being a bit sore, look at what you're doing. Are you keeping your breast still? It's very tempting to move your breast. So there are two parts involved here. Only one part should be moving, and that's the baby. Breast stays still. This is really important, that the breast stays still. The baby is the moving part. So this is the baby's mouth, and the baby comes to the breast with the chin and lower lip. This is the chin and lower lip, hitting the breast first, and the upper lip skims the nipple. So it's up here. So it looks like the baby's not going to go on. And you think, well, it's going right into the top of the mouth. The reason for that is that here's the hard palate, here's the soft palate, and here's a rasping tongue. The baby takes the breast in, uses its tongue, and takes the nipple right to the back of the mouth. Nipple is now sitting up against the soft palate, which is a bit like a cushion for the baby's, for your nipple. And the baby then does this. This is how they feed. So you've got a hard palate and a tongue. So I always explain it's a rasping tongue. If the baby goes on with the nipple in the middle of the mouth, so central, the baby does this. And this is why mothers get sore. This is why you get a very sore breast. So you can imagine the nipple can't cope with that stress, but the areola can. The areola can, and the areola and the breast can. Nipple cannot, and that's why you end up with a cracked and sore nipple. So think about asymmetric. So when I do it here, I talk to mums, I often do it that way. When I'm talking to mums, I talk about nose to nipple, and then the baby tips the head back, and they're now upper lip to nipple, and the nipple's here, and then the baby goes on in that movement, right just underneath. And if I show you the picture again, that I've showed you a million times before, if I show you this picture, you can see where the nipple is in relation to the upper lip. And this is really important, and this ensures an asymmetric attachment. So you can see all the gap is here underneath, and look where the chin is in relation to the breast and the nipple. It's right down here. This makes such a difference. That's what I'm always looking for. When I've got students coming through breastfeeding clinic learning how to help mothers, this is what I really fixate on, because this makes all the difference. And I could point out to you that we've no idea what position this baby is in, because it could be this baby's feeding in an upright position, like that. It could be it's underarm or cross cradle, or it could be even the baby's coming over the mother's shoulder. So it's irrelevant where that baby is in relation to the breast. It's what happens here that makes all the difference. And as I mentioned earlier, no two breasts are identical. So where you might have the baby sort of coming up from underneath on one side, you might have them straight on the other. You're always aiming to get this right. And the breast is the bit that stays still and the baby is moving, so the baby comes straight on. You can see the mother's hand here. That's here. The baby is going to be pushed from this part of the hand, no higher. So the baby is going to come on in that movement, not this movement. If the baby goes on and the head is tilted, the nipple goes into the middle of the mouth. If the baby comes on with the head back, the baby goes on like this. So that's a quick recap on positioning and attachment, because it is pretty much our bread and butter. And the first thing we'll do, even if you come and see us, and many mothers do, thinking their baby has a tongue tie, the first thing we look at is positioning and attachment, because positioning and attachment is the key to great breastfeeding. So think about asymmetrical attachment. Chin and lower lip hip first, upper lip skims the nipple. Now, I can see some more questions coming through. Or another one, I should say, just one more. So Lindsay has said, hi, I wondered if the Trust had breast pumps to loan to patients within the community for short periods of time. For instance, I struggled to latch my last one on the right, and it was helpful to express from that side to avoid engorgement initially. Thanks. So Lindsay, we do. The community teams, and actually, here we go, Claire's answering you. My community midwife has referred me to see, I'm going to come back to that one then. I'll come back to that because I thought she was going to say about the community midwives. The community midwifery teams do have pumps. They don't have limitless pumps, but they do have pumps. So if you need a pump, it's very possible that the community midwives will be able to provide you one. We don't have them in the hospital. We have had in the past, it's been extremely difficult to get them back. It's much better organised by the community teams because they're coming out and they're in your area. We found that the pumps that we used to have here would just go for a walk. They never came back to us, and we spent hundreds and hundreds and hundreds of pounds on pumps that never return. So it's much better that pumps are organised by the community teams that are out in the areas, and it's much easier for them to then go and collect the pumps when they're no longer needed. Most teams will allow you to borrow a pump for a couple of weeks, and that gives you enough time to decide whether you need to buy a pump for yourself or you don't need it anymore. And as I mentioned earlier about the pumps, there are some very good domestic versions of the hospital grade pumps available. So Medela, Ardo and Amida all make smaller versions. The Ardo Calypso is a very good little workhorse. It costs just over £100 and it's a double pump, and it works really well. Those were some of the ones we had in clinic which sadly had never made it back to us, so we certainly think they're great pumps. I mentioned at the beginning there are pumps for all people. There are some of you may have heard of the LV pump. The LV pump is a pump that fits into the bra, so you can go about your daily business and the pump is working on your breast. That doesn't suit everybody, not everyone likes it. It can be liberating because if you're pumping using pump kits, it means you have to be sitting somewhere and you can't be doing something else. We would feel that when you're trying to stimulate your supply in the early days, a pump that involves you being able to get your hands on the breast, which you can't do with an LV, would be better, to be honest. The LVs definitely have a place, but when you're stimulating your supply, a pump that allows you to have pump kits on the breast. I'm just going to see if I can see we've got them. Yes, we have. So, for instance, this is the pump kit that goes with an Ardo or an Amida pump, but we would be suggesting that you hold it onto the breast. And this allows you to be tactile. The LV fits in the bra, so the LV would be great for the sort of mother who's pumping maybe in the morning and able to have milk for the baby later. But if she's really working and having to massage and compress the breast, the LV doesn't allow you to do that. But it's what I was saying about horses for courses. And I've met mothers who don't need a pump at all, who are so good at hand expressing they never needed a pump, and they can hand express off gallons and gallons of milk, no problem. So just because you need to express your milk doesn't mean it has to be a pump. Your hands can be absolutely brilliant. Some women are fantastic at hand expressing. So thinking about that, Lindsay, yes, community midwives do have pumps for short periods of time, but also there are some quite reasonable price pumps available. Claire has said her community midwife has referred her to see the feeding specialist before baby arrives, as I had 2 very difficult feeding experiences previously. Will these be with you or your team? Yes, it will, Claire. You will have been referred to us. We will have you on the system. I don't know how many weeks you are now. We tend to talk to you somewhere around 36 weeks, so 34 to 36 weeks. You'll get an email from us arranging a time, and it will be with one of us. It'll be me or Eliza or Sarah or Naomi. And what we do is we have a look at your notes. We can go online because we have your electronic patient records. We go and have a look to see what we've got there. We look and see what the midwife has told us about you, and then we talk to you and find out what happened last time and how can we try and ensure that you don't go through the same that you had last time. And it might be to talk about expressing and early skin to skin, and just trying to see if you've got risk factors for maybe, depending on what your situation was. But yes, it will be with one of us. Oh, you've put up how many weeks you are. I've just seen 32 weeks. Yes, you'll be. It's a telephone appointment, so it's all done on the telephone these days, which means it's much easier for us to arrange and you to arrange. But once you've had your baby, we will, if we've done an antenatal appointment with you, we will generally make a big effort to come and find you once you've had your baby and try and make sure that the plan that we put in place with you, because it's an agreed plan between us, the plan that we put in place is being put into, being put in place with the teams that are looking after you, whether you're still on delivery suite, observation area, or up on the ward. But yeah, we would follow you up afterwards. So next few weeks you'll be hearing from us. I was going to say, if it was me, if it's 32 weeks, it wouldn't be me next week. But that's really 32 weeks. It may be because I'm away next week, but so it could possibly be me. Oh, Lindsay's come back and said she used the Ardo Calypso last time and it was very good. They are very good little pumps and not horribly expensive. They don't break the bank. They're pretty good little pumps. There are lots out there. I mean, we've had in the past, we've had Medela pumps and Ardo pumps and Amida pumps in clinic. We know that quite a lot of mums like the Bella Baby. It's a very reasonably priced pump that comes in at about 50 pounds. The Bella Baby doesn't suit everyone though. I'll just get that out there. So when we talk about the funnels, you can see the funnel size here. A mother who has a bigger nipple, maybe a bit like this, I don't know if you can see how big this nipple is, might not suit a Bella Baby. A Bella Baby would suit a smaller nipple. Would you believe it? None of my knitted breasts have got small nipples. So the Bella Baby has quite a small hole here, and so a mother who's got a bigger nipple might find it uncomfortable, because when you're fitting the funnel, the nipple should move freely inside, so it shouldn't rub. So it should be there and not rub. I don't know if you can see that. It gets drawn in, but it should not rub on the edges, and the pressure from here should be on the areola and not on the base of the nipple. So there should be some movement of the nipple into the funnel. So if you've got the Bella Baby and a bigger breast, the breast will rub, the nipple rubs, and actually that's not great. So a Bella Baby's fine for anyone who's got small nipples. Anyone who's got bigger nipples, it isn't a great pump for you. Look at some of the other ones, because they don't seem to have a choice. When you buy Medela or Ardo or Amida, they have choices on funnels, but the Bella Baby doesn't have a choice, and I presume that's reflected in the fact that it is a very cheap pump, but in comparison to other pumps, it's a very, very good economic pump, I shall say, as opposed to cheap. But it does work for those that have it and it fits. They really like it. It's a good pump. Claire's just come back and said thank you. That's brilliant. So we've got about 15 minutes left. If you've got any more questions, think about them. If you haven't posed your question already, or I haven't read it, then please put it back on again, and we'll answer any other questions coming forward. So we've talked about pumps. We've talked about stomach sizes a little bit. I'm going to go back to stomach sizes because that's something we talk about quite a lot. So when we were asked about, how much to give a bigger baby, just to remind you, those that have not had your babies or in the early days, we talk about a baby having a stomach the size of a cherry in the first instance. Now this is just, tiny weeny amounts. When we're helping mothers to express, in the first instance, we're looking at using a syringe. And the reason that we use a syringe is it allows that thick and gloopy colostrum, because colostrum is really thick like golden syrup, to be collected in a syringe. And if you go and watch the video that I took of this fabulous mother collecting it, you'll see that she is managing to collect her colostrum droplet by droplet, by pushing back the stopper on here. So she's hand expressing with one hand. Let's put that down. She's hand expressing here, and she's collecting here, and she's very, very adept at it. Many mothers find in the beginning they need someone else to help to collect the colostrum. Colostrum will appear in tiny little droplets. First off, you see a glimmer, you see a little shimmer, and then it starts to build up droplet by droplet until it's big enough that you can collect it. And initially, when you first do it, you may get nothing, as I mentioned earlier, and then you might get 0.1 like this. That would be a great start. And then as the first day goes on, you start getting a bit more, and by the time you get into day 2, you're getting more and more and more, and day 3 we're moving into much bigger volumes. So this is reflected in this. So we've got a cherry as the size of a stomach for a baby when they're first born, moving on to a walnut, so you can see a lot more will fit in there, moving on to an apricot at a week, and an egg at a month. And it's amazing how much you can fit in an egg. Remember I was saying I might be talking about 80 to 150. And here we're talking about tiny amounts, because that colostrum is a food in concentrate. So when I was talking earlier about the plan changes because the situation is changing very rapidly in the first few days. A baby is born not needing big volumes of milk, and in fact what they need is that protection that colostrum provides. They also don't want to have their kidneys and their liver overloaded with big volumes of fluid that they've got to process when they're just starting to get used to extrauterine life. So it is on purpose that colostrum is tiny, mini amounts. And that's why when I said about the checklist, this pre-72 and post-72, that's why it changes. So we get people saying to us, but I kept being told different things. It depends when you're told something. So things do change, because as you can see, the baby's need for food changes quite radically. It goes up quite radically. So we're thinking here with colostrum, by the time we get into day 3, we're moving into the realms of a mother's milk coming in, and the volumes will go up and up and up really radically. So we can be hand expressing glimmers of colostrum one day, and within 24 to 48 hours pumping 20 mils, 30 mils, 40 mils. So it really does change really quickly. And as was mentioned earlier, when the baby's going to the breast, you don't know. So what you're going to be looking at with with the baby is what's happening poos and wheeze wise. So I'm just looking to see if I can find my booklet with the poos and wheeze in it. Just thinking about how do you know your baby's getting enough food. So thinking about your poos and wheeze. So page 17 of Off to the Best Start. If you're coming in for the 36-week scan, ask for a copy, because they've got them there to hand out. You're looking to have black poos at the beginning that are so thick and sticky that you can't get them off with cotton wool water, which is what we asked you to do. We're having a laugh, really. It's a bit unfair on you, but it's much better for the skin. Then you'll notice it comes off with cotton wool and water much easier in days 2 and 3, and then yellow by day 4. This is what we want to be getting to. If your baby's poos are not yellow by day 4, please tell your midwife and get hand expressing, because your baby needs more food. Okay, and we're looking for the wheeze to go up day by day by day. So the first day they may only have 2 wheeze, the second day 3 wheeze, the third day 4 wheeze. So until we get to day 6, where they're having 6 heavy wet nappies. So, right, Erin has popped another question through. Oh no, I've got a question from Libby first. Let me just check I've answered all of those ones there. So we're going to hear from, that's Claire. Libby has said, if my baby has longer legs, is it harder to deliver? No, the legs will have no impact. No, that's absolutely fine. Legs are great. They just come slithering out. Don't worry about the legs. That's not a problem. Lucky baby having long legs. That's something I've always hankered after. Don't worry about the legs. That's not a problem at all. The legs are great. They just follow the body. Erin has said, I'm sorry if you're not the one to ask, do you know if there's an update on whether we can have 2 birth partners yet? I've seen a number of the other trusts are allowing 2 again, hoping so much my mum can come. We're due in December. Erin, I have to say, I can't answer that question. At the moment, it's definitely just 1. Wendy would be the person to ask, Wendy Randall, who does the Ask the Midwife sessions. I think she's doing them every other week now on the Monday. That would be a question to pose to her if we know there's going to be any change on that. Certainly at the moment it is still just 1 partner in the room. Our birthing rooms aren't huge, and obviously we're still working to COVID restrictions very much. So that is probably part of what's going on, why we don't. And obviously, you know, you'll have a midwife through your labour, and at the time of birth there will be 2 midwives, and there may be even a student, and we have to have the students in because that's how they learn. So you can imagine it can get quite busy in our fairly small delivery rooms, which is, I'm sure, part of the fact that we've only still doing 1 birthing partner. But definitely, Erin, have a log in when Wendy's doing her session, and she would be definitely the person to ask on that one. So, any more questions? So pop them through. I'm going to say hello to Charlotte and Alicia because they may watch this another time, because she's not been on today. They were in Devon last week, because they come on most weeks to say hi, so I'm going to say hi to them. I'll get them in there first this week. So there have been some great questions, and I wonder if you've got any other things you want to ask. A few older babies, and a few of you have not had your babies yet. So just reminding you, if you haven't had your babies yet, to access as much information as you can. So things like looking at our webpage, and I mentioned already that we've got a section on pumping. So if you go onto the OUH maternity website and go onto feeding, we've got a series of 7 videos, and we cover skin to skin contact, and why that's so important. If you haven't had your baby, it's absolutely crucial. Go and learn why we are so hot on trying to get you to do skin to skin. And I'm just looking, oh there it is, sat on its side, looking for this. The magical hour. That's your first hour after birth. This is an hour you can never ever get back. This is really important for those of you out there, the Claire and Erin and people. Have a read, look and find information about the magical hour and why it makes such a difference to have that first hour skin to skin. This is a point in time that your baby is learning about you. Your baby has never met another person, never met another set of breasts. Your baby knows the sound of your voice, is going to learn your smell. This is a point of time that it's a priming time, it's a learning time for your baby. Keeping your baby skin to skin, now that means only a nappy on the baby at the most, and very often not even a nappy, and nothing on you, so you're going to be bare on top. You could have sheets and blankets over the 2 of you to keep you warm and for modesty, but your baby's skin should be right against your skin. A baby's face against your chest is not enough. It needs to be skin to skin, as much of your baby's body as possible. It brings out the natural breast seeking and breastfeeding behaviour in a baby. The baby goes through 9 stages. This is what this post is all about. I know it's going to be back to front for you, but it goes through 9 stages. Every baby, regardless of where it has been born, whether it's here in Britain, whether it's in Australia, whether it's in, I don't know, the Antarctic, anywhere in the world, will go through those 9 stages regardless. It is inherent in babies, regardless of where they're born, to go through it. And they are born and they familiarise themselves with where they are. They rest, they move about. Have a look, it's great to see what they do. And there are some lovely videos about what babies do when they're born. Global health media videos are lovely, and they show, there was a lovely one on the breastfeeding section. Go and have a look at breastfeeding for mums, and they show videos of babies when they're born and what they do. And babies know, they're instinctive to go for breastfeeding. They have forward movement, so babies that are put on the chest down here will work their way up towards the breast. They are going to go for the smell, because the areola has scent glands. Those of you who are pregnant at the moment may have noticed you're getting little bobbles on your areola appearing, they're just little pimply things, and they're called your Montgomery's tubercles, and they give off a scent and lubrication, and that smells like amniotic fluid. So that smell is what the baby can smell on their hands when they're born. So we don't want to dry babies' hands, because it's like a scent pathway for them. They can smell amniotic fluid and they can smell it here. So they do forward movement, crawling towards the breast, and they're going for that smell. They can also see light and dark, which is why the areola is darker than the other part of the breast. So they can see that difference. So they're going forward movement, smelling, looking for the breast. If you watch the Global Health Media videos, you will see, I think they follow 3 mothers, and you watch these babies from birth until they attach at the breast, and it's absolutely beautiful. So where it fits in with us here, and this goes back to what we were talking about with the plan that I was talking about, Claire, with saying she's going to have a plan with that put in place with us. Often the first thing that goes on that plan is uninterrupted skin to skin contact. if you take a baby off and it's working its way through its 9 stages, so there's 9 stages are, it starts with a cry, it goes on to relaxation because it's just, oh, I've been born, and then it wakes up, so it's awakening, then it starts to move around, then it might rest again, then it's going to crawl, and I mentioned they can crawl, then it's going to find out all about its mother's breast. It's never met a breast before, this is the only breast it's probably ever going to know, and it's learning about this breast, and then it will attach and feed. If we take a baby off and move it and put it on the weigh scales, or we take it off and dry it or dress it and put it back, or it goes and has a cuddle, the baby has a cuddle with someone else, and we then put it back, this baby has to go back to the beginning. And after about an hour to an hour and a half, a baby will always fall asleep, regardless of where it got to in this 9. And then we've missed the opportunity, because this one down here at number 8, number 9 is the falling asleep, because that always happens. Number 8 is the suckling. And if that baby goes back and then ends up falling asleep and skips suckling, then we end up with a baby that doesn't know what they're doing. So it makes a really big difference if we can leave babies skin to skin, uninterrupted, on mother's chest until after the first feed. After the first feed, they can have a cuddle with someone else, they can be weighed, they can be dressed if that's what you want to do, but we do like them skin to skin as long as possible. And that's the timing for it. But up until then, your baby wants to stay on you. The smell of you is really important. Learning about your breast is really important. This is what we call a priming feed, and it's irreplaceable. We don't get this time back. So if nothing else, on your birth plan, have uninterrupted skin to skin, please, way after I've fed. And that will really help you have a very, very good start. Just checking if there's any more messages. No. So that would be my first thing when it comes to thinking about what can you do to plan a really good start with feeding, is the uninterrupted skin to skin contact. Knowing how to hand express is also really beneficial, because it's your first aid should you have a problem, as I mentioned earlier, baby too sleepy to feed, baby too upset to feed, baby maybe struggling to gain weight. Hand expressing is the first thing you're going to do before you ever think about a pump. And we know that if you're feeling engorged, actually you get a better response with your hand than you do with a pump initially. Get the milk moving and then use a pump. So these are all things that will really help for those of you that haven't had your babies yet and really get you going. Now, unless you've got any more questions, I think I'm going to sign off. We're going to have a week off next week. I'm on leave, and it will be me and Naomi the week after. So next week, which will be first week of October, there won't be a session. I will get Oxfordshire Maternity Voices Partnership to put that up on the website, just so you're not expecting it. But good luck to all of you, and thank you for your questions to Erin, and all the best to Erin. Maybe check out our website. And Libby, good luck with the birth and the legs. Don't worry about that. Claire, we look forward to speaking to you soon. And to Kate and Lindsay, and thank you all for your questions, and Tanique. Just checking I haven't missed anything. Thank you for tuning in and putting your questions. Oh, there's that another one there. Oh, Tanique's get it in there quickly. She says, me again. My little boy's nappies are good. His wheeze are plenty and poos plenty. Before he poos, he seems constipated, tensing and pushing to poo. Doesn't cry too much. He just fusses and cries a little. Is this normal? Yes, I always say that baby's a bit of a drama queen when it comes to pooing. I bet when he poos, they're not constipated at all, because constipated, if you think about it, are dried out poos. I bet when he poos, they're still liquid. So think about, he's just uncomfortable. So some babies, it does build up. We always say that we want babies to poo daily up until 6 weeks, but there are some babies that seem to store it up a bit, but then when they go, it's still liquid, it's still yellowy brown, so we're not concerned about it. So as long as that's absolutely fine. But if you bear in mind that this is all new to them, every sort of, like, hunger is something they've never experienced before they're born, and suddenly this is this horrible feeling of being hungry. But also, when their gut's getting ready to poo, it's uncomfortable. And where you or I might just go, oh, that's a bit uncomfortable, your baby's likely to make a bit of a song and dance about it. And that's completely normal. So as long as your baby's well and those poos are nice and fluid, like normal breastfed poos, because they are very liquid, that you're not getting hard poos, then I wouldn't be concerned. And it sounds really normal, Tanique. So thank you for keeping me going with another question. So last flurry, any more to come in?
feel like an auctioneer giving you last chances to put any more questions in. Thanks to you, those of you who've tuned in. If you've got friends that are having babies, perfect. I've helped a lot. Thank you very much, Tanique. She's come back and said yellow and liquid. Great. That's perfect. Not constipated then. Breastfed babies do not get constipated. A lot of breast milk. I mean, firstly, colostrum is a laxative anyway. So when you're giving your baby colostrum, that's what's getting them to poo in those early days. And then breast milk is also very fluid and it goes through the system very quickly. We find babies that are mixed fed do slow down a bit. Their pooing sort of frequency slows down a bit, but breastfed babies we do anticipate will poo fairly frequently, and it will always be liquid. So perfect, that's wonderful. Right, well, I'm going to sign off. I'm going to say thank you to you all for your questions. Store them up for 2 weeks, and if you've got friends who feel that they're a bit, could do with some more support with feeding, then do sort of pop them onto the, send them onto here, because we do love answering the questions. We know it makes a difference. And at least it makes us more accessible, because our clinics are quite busy. Any of you who've been to clinic will know that we do get booked up quite far in advance, which isn't great when you're feeding, because you often need help right now. All right, thank you very much, and see you in 2 weeks.